Well, thank you for this opportunity to address the committee. When an individual is unable to make decisions for herself, a surrogate may need to step in to do so. The range of decisions surrogates may be called to make cover the full range of human experience. Most commonly, we think of healthcare decisions or financial decisions, but the decisions may be as to residence, whether to divorce, whether to socialize with a particular individual. Regardless of the type of decision, there's three primary legal issues to look at. Who makes the decision? How do they make the decision? And how are they held accountable? I'm going to talk about each of those and then share some ideas about how we might improve policy and practice around surrogate decision making. So, who makes the decision? The law presumes that an individual is entitled to make decisions for herself. Whether an individual can exercise that right depends on their cognitive abilities. Different types of decisions require different levels of capacity. As a general matter, it's up to the states to decide what level of understanding is required to make a particular type of legally binding decision. The precise level of capacity required thus varies both on the type of the decision and on the state. So the first step in deciding who makes a decision is to figure out what type of decision and does the individual have the capacity to make that type of decision. Or if some underlying need of the individual was addressed or that individual was provided support, could they then make the decision? If even with enhancing the person's decision-making abilities, the individual is unable to make the decision, then we look to an appointed surrogate to step in. For financial decisions, that's typically your attorney-in-fact, appointed pursuant to a durable power of attorney. For healthcare decisions, that's an agent appointed according to what we alternatively call a healthcare proxy or a power of attorney for healthcare. It might also be a rep payee appointed by the Social Security Administration. Assuming there is no appointed surrogate, then the question is there a surrogate provided for by state statutory law? And this is really just in the healthcare context, but most states provide default surrogates for at least certain types of treatment decisions. And they choose them based primarily on familial relationship, which may not overlap fully with caregiver status. Finally, if all else fails, the surrogate decision maker of last resort is a guardian, and only to be appointed where you have an individual who is at substantial risk of harm and there's no other viable surrogate. So let's talk about how the surrogate makes decisions. Caregivers often describe their role as parenting their parents, but a surrogate decision maker making a decision on behalf of an adult has a very different task than an individual making a decision for their minor child. Surrogates are typically required to make decisions according to one of two statutory standards. Either a substituted judgment standard, making the decision they believe the individual would make if able, or a best interest standard, acting in the individual's best interest. In many cases, however, the statutes are unclear which standard applies, or the statutes may use a hybrid decision-making standard. For example, requiring the use of substituted judgment if you know the person's wishes, and falling back to best interests if you don't. How are surrogates held accountable? Well, we know that all surrogates are fiduciaries, meaning they have an ethical and legal duty to act in the interest of the person for whom they are making a decision, and to do so with a very high level of care. But how that duty is enforced varies. There's three primary types of methods we see used. One is monitoring the surrogate. So that may be periodic accountings required by the court in a guardianship case or by the Social Security Administration for rep payees. An individual may also try to monitor his or her own surrogate, although as a practical matter that may be extremely difficult to do. Um, Civil or criminal sanctions also can provide some level of accountability. And for many surrogates, the biggest threat may be the threat of losing their authority if they act in a way that others, including the individual, do not support. Okay, so I was asked to share some thoughts on improving surrogate decision making. Before I do that, I think it's really helpful to identify what the goals of surrogate decision making are in the first place. And so I've identified four goals for you. The first is to reach decisions that are substantively what the individual would want, are consistent with their wishes and values. The second is to reach decisions according to a process that's consistent with individuals' wishes and values. And we know that many older adults care at least as much about the process as the actual decision, even in highly charged healthcare contexts. A third goal is to reach decisions that promote the individual's well-being, social, psychological, physical. And finally, I think it's important to also recognize that we want to promote surrogate decision-making processes that respect the humanity of the surrogates, recognizing, as Kathy Kelly was talking about this morning, that surrogates are often called upon to make some very challenging decisions about people they're very emotionally close with. Okay, so what are some low-hanging fruit? What are some things we could do to improve policy and practice? First and foremost, I think we need to facilitate support for decision-making by care recipients themselves. We need to recognize that individuals who might otherwise be incapable of making decisions for themselves may be able to do so if provided support by a third party. And then we need to identify best practices for supporting decision-making and educate caregivers about those processes. And this needs to be part of the caregiver training that we are talking about in the last session. We also need to improve capacity assessment practices. Part of that is educating key players, both caregivers, care recipients, and those who are working with them, about what level of capacity is required for particular types of decisions. The capacity to make a will is very different than the capacity to decide whether to get that hip replaced. And too often, I think we assume that a diagnosis of dementia means a lack of legal capacity, or a lack of legal capacity in one domain means a lack of legal capacity in all domains. Part of improving capacity assessment is increasing access to skilled capacity professionals. Too often, those seeking to try to figure out what a care recipient is able to decide don't have access to individuals who are trained in capacity assessment. And so often we use assessments of cognition more broadly as a substitute, and a very poor substitute, for true capacity assessment. We also need to increase accountability of surrogate decision makers. Part of this, I think, and a key part of this, is enhancing the ability of persons with appointed surrogates to monitor their agents' actions. So I think we need to think seriously about bringing duties to consult with the individual into the underlying law of surrogate decision making. It may come to your surprise that, for example, an agent acting according to power of attorney in all but about one state has no duty to consult, no explicit duty to consult with the person they're making that decision for, even about fundamental transactions. We need to provide viable roads to guardianship restoration. Individuals who are subject to guardianship need to have a way to challenge that subjugation. We need to invest in accountability for guardianship and make sure that guardians' reports aren't simply filed away and lost. And finally, I think we need to rethink our approach to selecting surrogates in the first place. If what we want is surrogates to make decisions that are consistent with people's wishes and values, then we need to start appointing surrogates based, at least in part, on the extent to which those surrogates share the individual's values and preferences. Too often we rely on discussions about values and preferences, which the research suggests have very little impact on what decisions people actually make. The best predictor of what you'll do for another person is what you do for yourself. And we need to take that into consideration when thinking about how we select surrogates. And then, of course, finally, we do need to continue to encourage completion of advance directives, both to benefit caregivers and care recipients. So thank you for the opportunity. I look forward to discussion.
Thank you, Nina. We'll move on to M.D. Connolly.